Today we're demonstrating the use of the KAVS procedure on the short saphenous vein. So at this point the patient has undergone ultrasound mapping of a refluxing short saphenous vein, and we've identified the vein pre-procedurally for an access point. So we are going to use ultrasound guidance to access the vein. We will do this in a percutaneous method using a local anesthetic. So I'm going to actually visualize the short saphenous vein in a longitudinal fashion, not just to access the vein but also to thread the catheter and do the procedure. The first aspect of the procedure is to access the vein using a percutaneous method, so we're going to use some local anesthetic. Miss Sai, you're going to feel a pinch and burn. Ready? Local anesthetic. Pinch and burn. Although we can use the 9 French access sheath device, we can also, if we're looking to access smaller veins or smaller tributaries, or you want to first, in a more comfortable way, access the patient with a smaller needle, we can use a 5 French, and by exchanging guide wires then thread it up to a 9 French. It's not necessary to use a smaller catheter, but sometimes it's more comfortable for the patient. Little pinch. You won't want much of that. So you access the guide wiring. You may feel like a slight vibration in the leg. Mm-hmm. So then what we'll do is we'll outline the course of the vein by using the guide wire. We like to treat the portion of the saphenous vein that's parallel to the skin. So the previous named vein of Giacomini, now known as the posterior extension of the thigh of the short saphenous vein, are 2 landmarks that we use for the treatment of the short saphenous vein. Okay, so now we have our access. Okay, so next we will have prepared the KAVS triple lumen device that has access for a guide wire, a balloon device to occlude the vessel proximally, and we've prepared some sodium tetradecyl, which will be in a foamed fashion, consisted of 1.5% sotradecyl and a 4-to-1 mixture with air. So prior to inserting the catheter, we're going to check the balloon, make sure that the balloon works. So we insufflate the balloon. So once we test that, make sure that we aspirate all of the saline out. The balloon is filled with saline and not air. And we've also taken our solution, which even though at this point won't be foamed, we flush the catheter. So the solution exits the catheter distal to the balloon, because the balloon is going to be protecting the vessels proximally. Okay. So we're going to insert the catheter in, and under ultrasound guidance, track the tip of the catheter up to the site which we've determined the proximal treatment is going to be. So the tip of the catheter is easy to see. We can see us moving that, and you can see the tip very, very easily. So we're going to advance that. Because of the flexible nature of the device, in most cases for axial veins does not require a guide wire, but certainly for the more tortuous segment. So we're threading this up. Remember that we're staying in the parallel portion of the short saphenous vein, and right here where we see the posterior thigh extension and the vessel coursing towards the sapheno-popliteal junction, this is the level to which we would like to treat. So we'll stay approximately 1 centimeter distal to this. So here is the tip of the catheter at the arrow. Here is the parallel portion of the short saphenous vein as it courses down towards the sapheno-popliteal junction, and there is the posterior extension of the thigh of the short saphenous vein. So after the vein has been accessed with the patient in a reverse Trendelenburg position, we bring it to a level position. We're then going to use, under ultrasound guidance, we're going to occlude the balloon. So here's the tip of the catheter, right here. You may feel a little bit of pressure in the back. Feel that? Yep. Yep. Okay. So usually when the patient starts to feel pressure is about how much we'll occlude the balloon with. We don't have to insufflate it all the way. Next thing we're going to do is to retract the sheath, because you want to treat the entire vein. So the reason for the removal of the sheath is so that we're treating the vein in its entirety. Okay, so now we have a balloon occlusion. So you know what you can do with this? Well, as you can see, actually, although it's not air, you may be able to see a bit of flow. And sometimes you can see can't really see. Okay. Okay, so what we want to do is under ultrasound visualization of the device, where we can actually make out, as I pass the arrow there, the balloon itself, the distal part of the catheter, and now we're going to actually observe the fluid, actually the foamed sotradecal being infused. So we can actually see the balloon with saline in it right here. I can use that arrow quite nicely. That's the balloon. See it? Okay. So we're going to foam the sclerotherapy. Once again, 1.5% sotradecal and a 4-to-1 mixture of air to fluid, to liquid. 4-to-1 mixture of air to liquid. based on the size of the vein, the diameter of the vein, the length of the vein. We use a certain amount of sclerosing agent that we'll infuse. Today we'll be infusing approximately 3 cc's of foamed Sotradecol. So we're going to start the infusion. And you can see the ultrasound dense foam casting a shadow. What we also see is distal to the balloon, proximal to the balloon. There is no fluid, no foamed Sotradecol passing this point. This is a great safety feature when we're approaching areas such as the saphenopoppliteal junction, saphenofemoral junction, to avoid concentrated solutions in the deep system. So as we watch this ultrasound, under ultrasound guidance, the foam sclerotherapy being infused over 10 to 15 seconds. We're actually going to use the ultrasound probe itself to milk the fluid proximal and distal. So we get a good visualization. We see the catheter in the vessel with the foam sclerotherapy now totally filling the entire length of the treated vessel. Miss Sai, you may feel a little burning. A little burning. Hmm? A little painful, yes. Okay. So at this point, after infusing the solution, we are going to aspirate some of this solution. So since the balloon must stay in place, therefore the catheter stays in place, what we do is we're going to milk the solution from distal to proximal back towards the balloon, aspirating as we go. And you can do this a few times. So if the solution has taken effect in the vessel, for 15 to 30 seconds, we're actually aspirating some portion of this. You should actually get a shot of the fluid coming out of the catheter that's pink, because that's the blood-tinged fluid coming out of the treated vessel. So right there, yeah. And you'll notice that as you're aspirating, you can see the aspirated combination of the Sotradecol and a little bit of blood mixed with that solution. So that is the aspirated. So once again, distal to proximal milking of the vessel up to the level of the balloon. Okay, at this point we're going to desufflate the balloon in its entirety. We've now aspirated most of the solution. We're going to desufflate the balloon completely. So once again, once you have the same level of saline volume in your syringe that you had prior to filling the balloon, you know that you've aspirated it completely. So now that this is fully aspirated, what we'll do is we'll remove the catheter and the patient won't experience pain if the balloon is desufflated. Okay. One last measure. Place the patient's knee in a slightly flexed position and check to see that the popliteal vein is fully compressible, which it is. So the last thing to do is just to close the percutaneous site with a suture, which we recommend. How you doing, Miss Sai?
Are we almost done?
Actually, we are.
All right.
I know. That's it. We're finished.
That's
Is there any-